But it's been the snow.
I haven't. It's
That-
still on my, I kind of wanted to.
Amazing.
I was like, talk about a white finger.
Yeah,
I
literally,
really thought,
haha.
how even like.
Oh, that's cute. Aw,
how cheeky.
no, but it's true. Well, I just wanted to note, I'm like, oh, by November, usually the leaves are off.
Good afternoon, everybody.
Mm.
We'll call this Bridging the Gap Committee meeting to order. Couple things, remind you to silence your cell phone if you haven't done that already. Also, Francine reminded me that a number of us have been delinquent in turning in our evaluation forms. And I won't go through each name, though we have the names and you know who you are. Um, They'll be on the screen at our next meeting. But if you take some time and catch up on those, that would be useful. Let me see. Before we go into approval of minutes, just a reminder that our format is 20 minutes of presentation and then 10 minutes of question and answer. Next order of business, we have two sets of minutes. I would entertain a motion to approve both the October 14th and 15th minutes.
So moved.
Support. Been moved and seconded. Any discussion, questions, corrections, additions? Being none, all in favor signify by saying aye. All opposed, same sign. Sheriff?
Also, for the first presentation, I'd like to recuse myself since it's a sheriff presentation and there might be a conflict of interest there.
Would entertain a motion for the recusal.
So moved.
Second.
Any discussion? All in favor signify by saying aye.
Aye.
Opposed, same sign. Thank you, Sheriff. Anything else before we jump in? I don't think we have any old business. All right, our first item of business, we have Captain Casey with us here from our sheriff's office to give us a discussion about his proposal for the medically assisted treatment program. Thank you, sir.
Thank you and good afternoon, everyone. So I'd first like to start off by thanking this committee for giving me the opportunity to speak here today. I know it's been a long process for myself, but I've been kind of following everything that this group has been doing along the way in the last couple of months. I know you've been really hard at making sure that those dollars are spent the correct way, and that's very admirable. So thank you. So my name is Randy Casey. I'm the captain at the Lenawee County Jail. I've been in this industry for quite a while, going on 30 years of corrections experience. I retired from Washtenaw County after a long career with them. I retired as their captain and thought I was done wearing uniform until Sheriff Bevere called me one day and talked me into coming back. It wasn't a hard decision. I am very passionate about what I do. I know it's kind of cliche to say, but I like to help people. The job that I gave up to come work for the sheriff, for Sheriff Bevere, was a great job. But because I knew what Sheriff Bevere was trying to do here and the culture that he was trying to establish, I decided that coming to Lenawee County was a good option. So as the captain, I'm charged with a lot of responsibility, as you could probably imagine. Custody, security, contracts, staffing, you name it. But the one thing that I think is one of my biggest responsibilities is the safety and security of everyone in there. And to provide the inmate population with basic needs. And I learned early on that we weren't giving them some of the basic needs that they need. And that is the level of health care that they have when they walk through the door. So we know what recidivism is, and we know that people continue to come back to our facility. But I don't know that we have done a good job at the Lenawee County Jail of establishing those root causes. And there's a lot of root causes. And one of the root causes, which is why I'm here today, is to talk about the drug and alcohol addiction. And what I want to try to hopefully establish here today is that we can make a difference in the jail and prevent them from coming back. Not all of them, but a lot of them. And to do that, I want to establish, or we hope to establish, a MAT service in our jail. So what is MAT? So MAT is an acronym for medically assisted treatment. And basically what it is very specific medications that are scientifically based and proven to reduce cravings and withdrawal symptoms. And essentially, the medications coupled with behavioral therapies, we're hoping that it can help the inmates. So when we talk about accommodate behavioral therapies, what those are is essentially it's the individual counseling and the treatment programs, the SUD treatment programs that will be set up in our jail to help the inmates in conjunction with the medicine. So the medicines that they get, there's different types of medications. I'm not a doctor, so I don't pretend to know the exact effects that they have on them, but I think it reduces their cravings and it definitely helps with withdrawals. And if anyone has ever seen someone going through withdrawals, it's a pretty sad thing to see. We see it every day in our jail. And currently, there's nothing we can do for a lot of them besides give them Gatorade and some over-the-counter type medications to deal with some of the pain that they have. Next slide, please. So our ask. So we want to establish funding to acquire those medications for the MAT services, funding to establish a classroom-based educational process for the inmate population, funding to educate our staff on why it is that we're trying to do this. We need everyone at the sheriff's office to know that because you tend to get a little bit of a bias. You see the same faces coming in and out of our jail all the time. And you wonder, you forget what the root cause that brought them to the door was. And so if we don't educate our staff on why people keep coming back to jail, then it gets lost. And then they just look at them as the inmate that keeps coming back to jail. And then we're also looking for funding to provide peer support for the inmates that are returning back to our community, because treatment doesn't stop when we let them out, or at least we're hoping that it doesn't stop when we let them out. There has to be some level of support for the inmates once they are released back into our community. So let's talk about the why. Why is MAT services so important to our jail? So statistically, inmates that come to jail are 10 times more likely to overdose upon release. What happens is they come into our jail, they go through the withdrawals, and whatever, then they stabilize. And then once they get out, they go back to using the drugs at the same dosage that they were using prior to incarceration, and then they OD. And it's a very sad thing. We hear these stories all the time of a certain inmate that got out of jail and they OD'd. It improves the health and well-being overall. Everyone knows that incarcerated individuals have a higher rate of chronic health issues. People that are struggling with alcohol addiction, or SUD, it just compounds the issue of their overall health. Many times they end up in our emergency rooms. There's a cost to that as well. It takes our resources away from the jail. It takes our resources away from the road, and they end up in the ER. And we cannot continue to pay double of what it would typically cost because, again, we're not addressing the root cause issues. It decreases violent and disruptive behavior. there hasn't been any programming in our jail, unfortunately. Most recently, we have a jail program coordinator that has helped us find some educational services, some workforce development stuff. When the inmates come to jail, they feel hopeless. And when you feel hopeless, it tends to contribute to their disruptive behavior. By offering some services, something to help them, we hope that it will decrease the number of issues that we have in our jail. We hope that it would lower our recidivism rate. The goal is to make people a little bit better when they leave than when they came in. And by tracking this and hopefully being successful with it, we hope to be able to prove to this committee and to our board of commissioners that the Matt Clinic is working and show the fruits of our labor. It's a cost-effective solution. Long-term healthcare costs, minimizes the need for medical intervention, hospitalization. All of those things contribute to high cost to run a jail, and Matt Clinic can hopefully reduce those numbers. And overall, it reduces liability. When people come to our doorstep and they're at their worst of the worst, we assume a lot of liability. We don't know unless they tell us that they used, unless it's an obvious sign. Sometimes people can slip through the cracks. And heaven forbid, someone makes it to the back of the jail and we didn't recognize the need that they had, and they go through some severe withdrawals or they die. The courts, so Matt is in 16 states right now. It's a mandate throughout those states that Matt services is provided in their jails. And more, there are mandates that are coming. The courts have ruled, as you probably saw when you read my RFP, the courts are ruling in favor of the plaintiffs, which are the inmates, when we do not offer medications and treatment. It's considered deliberate indifference. And for those that may not know what deliberate indifference is, it's basically when you know you should be doing something and you just don't do it. And then the courts have also ruled that it is a violation of their 8th Amendment of cruel and unusual punishment. There's been a couple of local cases, one of which was Macomb County. Another one was in Grand Traverse County, where the courts have ruled in their favor as well for not providing MAT services upon incarceration. In this PowerPoint, I think everyone here probably got this in advance, and because of time, we can't click on any of the links, but hopefully you were able to click on a few of them. There's a dangerous trend. I found some YouTube videos and they extend back as far as 12 years ago, and the most recent one just 5 months ago, where people go to jail and they go through severe alcohol or withdrawal and they expire. They died in jail. And it's a sad thing because that is someone's son, someone's daughter. They're people, and someone is going to end up getting sued as a result of it. It will happen. We all know that. You can kind of get the checkbook out when that happens. And while we do our due diligence to try to prevent that stuff from happening, we only have so many resources currently. We have very good staff. They do their best to keep an eye on people who are going through withdrawals. We have a fantastic medical provider, but things happen. And we don't want the ultimate to happen in our jail. So I tried to get some statistics. There was a little bit of a void during the COVID era, but I was looking for some statistics to compare Lenawee County to our statewide far as overdose deaths go, statewide, at a 3-year average, from 2021 to 2023, they're over, well, close to 6,000 overdose deaths statewide. Lenawee County had 31, according to Michigan.gov. The next slide, starting in 2022, 2023, shows for 2 years. We talk about the ER visits, the number of times that somebody goes to the hospital as a result of an overdose. Statewide, over 57,000, and here in Lenawee County, 468, and many of those, no doubt, came from our jail. Took a look at the types of drugs that are being used as far as contributing to overdose deaths. In 2023, statewide, 72.5 were synthetic opioids. Lenawee County was a little bit higher than the average at 77.8. And examples of those synthetic opioids are like your methadone, your fentanyl, oxycodone, oxycontin, those types of drugs. So some facts. So if the overdose deaths, so the overdoses, emergency room visits, if they're happening in our community, you know, what makes us think that it can't happen in our jail? It's just a matter of, it's not if it will happen, it's more like a matter of when it will happen if we don't address it. Since January of this year, there's been over 150 of our inmate population that has gone on some type of drug or alcohol watch. Year to date, we sent 54 people to the hospital before they even came into our booking area. 22 of them never came back. And that just goes to show you how bad off they actually were. They never even came back. So our plan is to basically partner with VitalCore. VitalCore is our healthcare provider at the jail to provide the medications. We're also going to partner with Wayne State University. I just had a meeting with them yesterday. Wayne State offers up some technical assistance for helping us to identify people when they walk through the door through assessment tools, basically screenings that we insert right into our jail booking process. So when the inmates get asked a variety of questions, we now have some proven instruments that will help identify people with mental health disorders, substance use disorders, and so on and so forth. We want to partner with the local service program so they can do the educational component in our jail. I have a meeting tomorrow, actually, with someone in our community that we hope to partner with that can come to our jail and provide those services. We want to work with the courts. We're hoping that we can help reduce an inmate's length of stay if they show participation and success with our programs. Obviously, we want to continue partnering with CMH and then with Family Medical Center, which I believe goes right after me. I've tuned into a lot of these presentations, and I hear a lot of the presenters talk about partnering with us. I would love nothing more than to partner with as many people as I can. I think you can never provide enough care to the inmate population, but I hope that when the dollars are finally dispersed, that we can get a provider that can do what I know we can provide the inmates. So our goals. Obviously, we want to identify the individuals who need the help immediately. We want to prescribe the proper medications to reduce the withdrawal symptoms. We want to enroll inmates into the evidence-based programming. Again, we want to work with the courts, probation, all the stakeholders throughout the community that can help us. We want to provide connections to care prior to release from custody. There's probably no worse feeling than when we're walking that inmate out and we know they're coming back, because you can see it on their face. They're walking out the door and they know that they have been given no tools to prevent them from coming back. And then we're going to measure our success by collecting the data and evaluating our findings. There's a toolkit that the Bureau of Justice has that I've taken a pretty hard look at, that provides us with everything that we would possibly need in order to be able to identify where the program is and how we can make it better. And we hope to report that out quarterly to the board. And then also stepping up, Wayne State folks, they're going to help us with the data collection as well. So budgetarily. So we're asking for $150,000 annually, not to exceed $150,000 annually. And for those of you that are wondering how I landed at that figure, it was very painstaking, and I have no confidence that that's the actual figure. But the problem with trying to come up with a figure that I ran into is that everyone is situated a little bit differently. There are some jails with a tax base that can do wonders, such as Kent County, where they spend $1.5 million on their mat services. And then you have others who can't provide that. And so I think some of the lowest figures that I saw were 130,000. The funds will primarily be used for the medications. The medications are costly depending on what type you use. And then the actual funding for the training for our staff as well as the inmates. We hope that 2026 will help us establish a baseline for costs so that we can better give a better number moving forward. But right now it's too early because we have no stats to provide you. Some of the variables that determine the costs, again, there are multiple variables. What is the SUD rate, overall rate for Lenawee County? We don't know. It hasn't been tracked. The overall opioid disorder rate for Lenawee County. How many individuals will be participating in the program? What types of medications are we going to be offering? One of the medications, I think it's the Sublocade med. One injection of that is $2,300 for one injection. And so I wasn't able to land at a definitive figure, but any monies that are left over at the end of the year, we will gladly return for the next year.
We are approaching the end of your time.
So next slide. Next one. So we're doing our part as far as costs go. I recently I applied for a grant through the Bureau of Justice, and we were awarded the grant. That is one component of what we're trying to do, though, is more of a reentry initiative, but there is some overlap for Matt. And so we are going to be using those dollars to help with the programming component. Next slide, please. I kind of want to leave people with this. You know, I think it's easily forgotten when people get dropped off at our door that the jail is a part of our community. These are the same people that will be getting out of jail that we'll run into. There are our neighbors. They shop at the same places that we shop. They entertain at the same places we do. We owe it to all of them to make them a little bit better when they get out. And that goes hand in hand with the sheriff's mission. So we rise as one team to ensure professional services to our community. And I want to put emphasis on our community because the jail is our community. Next slide is just the resources that I used. And I want to thank you, and I'm opening it up for questions.
Thank you. Thank you for your presentation. And I am reminded that I think out of all the presentations we've heard, while we have various relationships with people with SUD issues, the folks lodged in the jail, we're actually liable for. I mean, we are their custodians, which is different than some of the other scenarios where people have at least some degree of volition as to whether or not they continue in the programs and so forth. So, but I could drone on all day. Questions, folks, I'm sure you have them. Judge Morgan.
I know you said you're looking at $150,000 annually. Obviously, what this committee has is a finite amount. What do you believe you would need to get started? And then, of course, it would be up to the county commissioners to determine going forward. But what would you be requesting as a initial get started, get everybody trained and come up to speed?
Can I say 150,000? I would ask for the full amount, knowing that I can give it back if we don't use it. But it's hard for me to say, Your Honor. I would know more tomorrow after I meet with one of the local service providers as far as the actual classroom-based stuff. But the medications that will be needed, we need to decide as an agency what types of medications we're going to offer, because depending on what we give them will determine the cost. And so I don't want to kind of put the cart before the horse, but I would hope for the whole 150, but somewhere between 100 and 150, I would say.
Anybody else? Other questions? Rana?
Thank you. Thank you. You had mentioned, very, very informative, by the way. Thank you for your presentation, and the liability piece is noted. And the mandate that 16 other states have to require MAT services within jails, and it sounds like that's a trend that might be continuing. Has that been around long enough to have any sort of data on recidivism rates for states that are mandating this, or for jails that already have this in place, versus recidivism rates for those that don't have MAT services?
So if you go on the web, you can find just about anything that you're looking for. Again, there was a little bit of a lull during the COVID era where people were obviously taking care of other needs. But just yesterday, I met with a gentleman that used to be the undersheriff from Kent County, Chuck DeWitt. And they did a study. So he now works for Indivior, and they are basically a provider of a medication called Sublocade. And they did a study. Basically, 533 individuals participated in this study, and it was done over the course of 18 months. And there were 50% did not return to jail as a result of participating in that clinic. I don't have any other data specific to Michigan, but there are a lot of very good success stories out there.
Thank you.
Terry, then Jim?
I have several, obviously time will not permit me to allow them, but what's the current status of treating SUD problems in the jail?
Well, the current thing, so they do offer something to help with alcohol withdrawal. They do. They are our medical provider, Vital Core. So we contract with Vital Core. They're our medical provider. And they do offer a medication to help with alcohol withdrawals, but nothing for opioids. So the current protocol is we put them in a cell, they sweat it out, we'll see you on the other side, and here's some Gatorade.
Okay. Now, you mentioned that one, you want to have programs, classroom type programs in the jail. And also that you want to have follow-up programs after release. Is this $150,000 you're asking for funding those programs?
No, there's components to it. So obviously there have been other presenters that come here in the community that offer services, outpatient type services. We want to make sure that prior to the inmate leaving and going back out into the community, that we've established contact with them.
So the
So-
assumption is that one of those agencies is going to be funded to the point that they can handle this.
That is correct. We will help with the peer support, basically the conduit between the jail and said service. And then we'll make sure that there's follow-up and that there's a warm handoff.
The staff that's teaching the classroom style substances are trained therapists or
Yes, they are.
this is going to fund that part of the program?
Yes, sir.
I guess I'm confused. You're saying the vast majority of these funds are for the drugs, yet you're going to hire people trained
We're gonna contract for those services
as part of this hundred and
as
fifty.
part of this, yes.
Jim?
Well, thank you, Captain. Couple questions here. Mandated, when I hear mandated, that always gets me kind of excited. So, were those, court mandated, legislative mandated? How, do we know how they were mandated?
They were both. Some of the states were executive order and then the others were court order.
And funding, once you do a mandate, where'd the funding come from? I mean,
I'm assuming that it came from the taxpayers.
wonderful legislative, but, so we, in your entry process today, we don't have, Ron is familiar with those mandates too. so. We don't have a process today where we come in and we sort out these people that we're talking about, you know, like, whether they're drug, you said, mandated treatment when they come in, we don't screen
Yeah,
them today.
we screen and screen and screen. From arrest on the street, they're asked various questions relative to substance use. We triage them in the Sally Port before they walk into the booking area and ask them a variety of questions. We book them in and ask them these same questions. But people aren't always forthcoming or honest. And then you find out once they've been in jail for 3 or 4 days and they're deteriorating in the back of the jail that that they were missed. And so these instruments, it's called Case 6 and a RODS instrument. They're all backed by doctors and they're inserted right into our booking process. And it is designed to help us better identify people who have these needs.
So one other quick question, if I may. So, say you're funded for this program, the group makes their recommendation to the commission, says we want this to happen. Can we force these people to do this? I mean, if they come into the jail, I mean, is it an automatic thing that,
No, so we cannot force anyone to participate. The courts can put some leverage on participation when you talk about helping with potential for early release or release for probation and things of that nature. But no, you cannot force people to do it. It is a volunteer.
so it's an education process as you bring them into the system to get them to understand that it's going to help them, and then that if they want to sign up, that's the only way you're going to get them to move ahead.
Perfectly said.
But if they're in medical distress, then you have an obligation to intervene.
We do. And then,
Okay.
and we have great medical staff. A lot of times they end up at the hospital though.
So I got 2 questions as we run out of time. So currently, just so we're clear, the only medical intervention you're doing, MAT intervention is for alcohol. You don't have the resources to do anything for opioid.
Zero.
Okay,
That's correct.
so that's not taking place. Here's another question. Of course, you've seen some of these other presentations. We have more than one, I forget how many, who have said they will partner with our jail if we fund them. And now your proposal says if we fund you, you will partner with them. What's the preferred approach, and does it matter? And would it be less overhead for you guys if this was funded through an external agency? Do you have a strong understanding your staff is going to need some training
Yeah.
irrespective of this? What are your thoughts on that?
So Because I've been doing this a lot of years and we've had programming at Washington, quite extensive, a lot of programming at Washington County. We want, the sheriff's office needs to have the say in who's coming in to provide those services. I trust that everyone that asks for dollars, has good intentions, but we want to make sure that it fits what we're looking for from the sheriff's office. And so I hope it's that we're able to partner with them rather than the latter.
Understood. Any other questions? Well, thank you for your time, sir. Appreciate it.
Thank
I
you,
would
everyone.
just offer a comment to everybody, seems like the county government has a few areas of contact with folks with these issues, either through community mental health, through the courts, or if they're incarcerated. So whatever series of initiatives we finally adopt are going to have to address those points of need, which also means the folks who are engaged in those areas now as agents of the county certainly want to take into consideration what their concerns are, because they're very much on the front line. So thank you. Any other comments before we bring up our next, this is our next person, right? Oh, so Mr. Swearinga, am I saying that correctly? All right, super. And you're with Family Medical Center. Welcome. You have 20 minutes to present and then 10 minutes of question and answer.
Rose should be walking in any minute. Google brought him down some gravel road on the way here from Detroit. So he's walking in. And then we also had a recovery coach who's gonna be here today as well to speak for a few minutes, but he was up north in the UP and they closed the bridge yesterday because of the wind apparently. So he couldn't get across on his bike. So I will be covering his part. So yeah, thank you. This is kind of my CEO's part, but I'm going to get started, and when he walks in, we'll have him take over. So Family Medical Center is a federally qualified health center. It was founded in 1972, originally in Temperance, Michigan, so been around for a lot of years. And our mission is to provide services to all, regardless of their ability to pay. And so it's federally qualified health centers primarily for primary care. And this is our CEO, Ed Larkins. So I'm going to kind of have him take over. I just got started. We just talked about the founding and the mission. So I'm going to let you go from there.
Yeah.
Right.
Oh, sorry I'm running late. Actually, I was in Detroit with Travis. I was following my GPS and turning the wrong direction. Apologize. So anyway, as Travis pointed out, I'm the CEO of Family Medical Center. So I've been there for 21 years as a CEO. So as Travis pointed out, we were founded in 1972 in Temperance. So we have sites in Temperance, Carlton, Monroe, of course, in Adrian. Plus we're at 56 schools, I believe, providing behavioral health services in Wayne County, Lenawee County, and Monroe County. So we started here providing services in Adrian in 2014. We partnered with a free clinic at the time. And the reason we did that is because we had a number of individuals from the Adrian area driving over to Temperance for services. So our board of directors, we have 15 now, decided that we need to have a presence here in Adrian. So with that said, we started very small. I think we started in 3 rooms across the street from the old hospital, which is now torn down. And we were able to build the building. I don't know if all of you, of course, know where the ice cream place is, Spotted Cow. I use it as a reference. We're right next to the Spotted Cow. And we're proud to serve this community, serve the county. So with behavioral health, I'll give you the understanding how we got involved with behavioral health. Umstead, I forgot exactly where Umstead is located, but it's a very small town. And we decided to partner with them years ago to provide medical services. We bought this equipment, unfortunately, because Armstead is in an area where the connectivity is poor. We can never get the equipment to work properly. So in speaking with the principal and others there, they said, well, why don't you try behavioral health services? So we did. And it was such a great success that we are now, as I mentioned, in 3 counties providing behavioral health services. So you want to go to the next slide? Oh, there we go. That's how that works. I know nothing about technology. So you can see by the slide, we provide a lot of different services. So our Adrian site is actually our largest center in terms of square footage and type of services we provide. So it's just slightly larger than our Temperance Center. So if you want to go back to that slide, please. I just want to kind of talk very shortly about what we provide. So you see optometry. So we have an optometry clinic in our Adrian site. We just opened that up about a year ago. We have a full-fledged pharmacy, and that's very important for our MAT SUD services to have a pharmacy located there. We partner with City of Refuge for home delivery of food to about 330 of our patients. And that's very important given the environment that we are now in. And let me go back to MAT SUD. So that's what we're here for. So our MAT SUD services actually started on a very small scale at a Temperance site. So Dr. Chu, who's our medical director, he might be here shortly, really brought this to our attention. He's generally stationed as a provider in our Temperance site, but he comes to our Adrian site 1 day or 2 days out of the week. He's here at our Adrian site today. He brought to our attention really the need for MAT SUD services. This was about, let's say, almost 5, 6 years ago. So we started providing these services at our Temperance location on a very small scale. So he was our main provider, and he decided that he needed to talk with other providers within our centers. So the providers in Temperance, providers in Carlton, and the providers in Monroe. They all are engaged. These are primary care provider, family practice providers, provided MAT SUD services. So when we think about these services, and he's the expert and Dr. Chu's the expert, no, I'm not. I just know that it's extremely important to the communities that we are in to provide such services. So, we partner with a lot of organizations, ProMedica Hospital being one of them. With that said, we though, in the counties that we are in, especially this county and in Monroe County, we are the providers of the MAT SUD services that our patients require and that they need. So, Dr. Chu just walked in. Relax, Dr. Chu. I took the stairs, that's why I'm breathing. I'm an old man, it's hard for me to go up and down the stairs. So I just want to give you all an overview of our health center, because what you see on North Main Road certainly is important to our organization, but we are a fairly large organization spread across 3 counties. So, and as you can see from the pictures, these are our centers here. And we are in many schools that we just mentioned. Next, please. Okay, so MAT SUD services. So I'm going to introduce Dr. Chu. Can you talk for 3 minutes? Yeah, so why don't you come up, Dr. Chu? So Dr. Chu has been with us for how many years? 32? 35 years? Okay, so Dr. Chu has been with us 35 years. Let's say I have been the CEO there for 21 years. How long have you been with them? 3 years. So he's a baby of the group. So I'm gonna have Dr. Chu really just talk about from a clinical perspective, the services that we provide to our patients for MAT, SUD. You can do that?
Just a quick reminder before you begin, where are we at with time, Jen? You have it? Okay, I think we got about 10 or 11 minutes left to finish your presentation, so be conscious of that. Thank you.
I think you know that the problem with opioids is because of the it's a medication causing tolerance. Then you are increasing dose, but they treat for pain, but also they had the euphoric type of, pressure type of situation causing people, like to take the medication even without pain. So for the pain wise, it's when we treat it for a long time, it will increasing dose needed to provide the same amount of pain relief. But most of the people doesn't like that because you're increasing the dose, they can get into a situation of need to take more and more, as well as withdrawal symptoms. When they get into withdrawal symptoms, very uncomfortable to live and cannot work. So the reason why buprenorphine can be a solution, certainly methadone clinic have been for a long time working on that. The methadone had a good solution because it is a partial agonist. What happened is it binds to the receptor more tightly. And also it had a potential of kind of lower down the receptor. That means it reducing the person who are craving for opioid. And so for this kind of situation, causing them to, only take one in the morning or whatever time is, then the whole day they're doing well without any symptom. So they can work like they usually working. So doesn't affecting their situation of like sedation. It doesn't affecting them in a lot of other areas. So they can live a very healthy life if just taking that buprenorphine. So that's the reason why it's important. They can resuming a routine, healthy lifestyle. The second thing is it doesn't give them a euphoric type of symptoms. So in that way, they are not going to get craving and relapsing. So that's why the program is important, that to help them to recover. And also for our program, we're very unique in a way that we would like to help them to be drug-free. That means in the future, we'd like them even not need the buprenorphine and live a healthy life like any other people. Now, how unique our program is this. We had the medical provider who is not a specialist for addiction treatment. So that means we treat them with the medication for buprenorphine, as well as we take care of their medical health. If they had diabetes, we take care of them. If they had other conditions, we are a medical provider, so we are capable of taking care of them in the general whole being. So that is one thing. Second thing is we also understand that for anyone who had opioid dependence or disorder, they are not just the biological, physical problem. Also, there is a mental problem. And so we had a behavioral group who can take care of them. We have psychiatrists, we have behavioral health consultants, we have counseling service, so we can help them in terms of the behavioral part of the well-being. Certainly, there's another thing is also that a patient who can be stable in the environment, they can have a healthy outcome. So we also had the resource person, the community health worker, who help them to deal with like housing or any kind of like financial food problem. We had, community resources that we can get into and introducing them to help them. So that in terms of their biological, behavioral, and social wise, we're all, looking into helping them with that. Also, you know that those who are substance use, they use the methane, they had teeth problem. They also, using the buprenorphine because the saliva sometimes causing teeth problem. We also had dental department to take care of them. In addition, another thing is we had a very important personnel that is a peer support coach. Because at the very beginning, I tell them that if they are going to walk through this long journey, they need to have a peer to help them. And we had the coach, we had the best coach in our system to help them go through this problem because of the peer coach also is a substance use recovery person. They can speak the same language, they have the same condition, so they are very good helping them rather than just a specialist who doesn't know what is addiction mean rather than reading the book and using the medication. So I think we get back to.
Yeah, so Dr. Chu is explaining, the team that really supports Dr. Chu and other providers. So we're gonna have Travis to come here and talk a little bit more about the team, but give you a little bit more overview.
About
But
5
that
minutes.
Team is extremely important, and Dr. Chu and our physicians head up that team. Under that team are the sort of providers, the support that's given to the clientele.
Right, great. You can go to the next slide, please. So just some basic information about kind of Lenawee County, some statistics around opioid-related issues. I think the two most important ones for me really are the bottom 2 points on the left side there, that 85% of the individuals in our community who need treatment aren't receiving it. And then just the rural nature of our community and the limited number of providers really make access difficult. So thank you. So just in terms of kind of our program overview, our goal is to expand access to MAT and mental health treatment for those who are uninsured and underinsured in our county. Our objectives are to provide MAT service to at least 50 Lenawee County residents annually, in addition to what we're already doing. So like Ed and Dr. Chu have said, we do currently provide MAT services in Lenawee County. It's limited at this point. We're kind of limited in what we can do, just in terms of it's expensive to do, as you'll see as we look at some of the numbers. But we want to certainly increase access to care. You heard the captain from the jail earlier. We have worked with the jail in the past and would work with the jail on this as well. And like I say, they need funding in the jail to initiate it in the jail. And then when people come out into the community, funding is needed to continue that treatment. So unfortunately, it's hard to fund one side or the other. The funding is kind of needed on both sides, unfortunately. But we would work with the jail. We've already got some processes and things in place to be able to work with them and their peer support and their staff there to identify those inmates who are on MAT services, who are being released, and we can do the warm handoff and start services the day they walk out of the jail. They'd actually get transported to our site, see a provider, and continue the services that they've started in the jail. So it's kind of a really nice process. And then ultimately what we want to, the goal is to improve the health of our residents in the community. We just know that MAT services help people improve employment, housing, relationships, family stability. It reduces recidivism back to the jail. There's just lots of benefits to it. So this is the cost breakdown that we're talking about. So you can see staff costs in there. It's in the proposal as well, but it's about $174,000 for staff costs. Medications, as you can see, are incredibly expensive, particularly the injectable forms, which is kind of the preferred form for the patients as well as the providers, because it can be given once per month, once people are kind of started on a oral medication to make sure there's no side effects. The injectable medications just seem to work much better. So the medications are expensive, unfortunately, and then there's lab costs that go with that as well, because we do ongoing monitoring not of just sort of other drug use to make sure there's not contraindications and that we're not putting patients at risk. But also, we're looking at other health conditions. We just know that people who are struggling with opioid use disorders have lots of other conditions that they're struggling with as well. Next slide, please. So this is kind of our implementation plan and timeline. We can get started up pretty quickly, if we're approved for the grant funding. We have some staff in place. We would just shift some of the FTEs around and the focus on what they're doing, and we would have to hire some staff as well. But we should be able to be going within 90 days to be able to really start taking on those 50, minimum 50 and potentially more. The goal would be to take on more. And then as we're looking at our kind of evaluation and outcome measures, we'd be obviously tracking the number of patients that are getting treatment through this grant funding. The percentage, so, obviously if they're taken from the jail to our doors, we're hoping to, basically be at 100%. There are always things that happen, but, we certainly want to track those percentages to make sure that we're catching a high rate of those who are coming out of the jail and keeping them on those services.
That is your time, sir.
Okay, all right, thank you.
You might have a chance to expand a bit more with questions, but thank you for that. Questions? Terry?
As I'm hearing this presentation, your program revolves around those who have an SUD and the treatment is forward. Do you have any programs, any educational programs, treatment programs for those youth, for example, to stop the use of drugs before it happens?
Yeah, so in our schools, as Mr. Larkins has talked about, we provide therapy directly in our schools in Lenawee County and Monroe County, as well as Wayne County. So we do educational sessions. We coordinate with the schools on a lot of that stuff. So we'll do it around substance abuse. Vaping's huge in schools. Bully. So there's a lot of sorts of psychoeducation we're doing in schools and in the issues that the schools face. So we do some of that, yes, in our schools.
Jim?
So you currently are offering this program throughout a number of your units. So the additional funding that you're looking for here is to supplement that so that you can take in more people. Right now, is it underfunded because you can't cover the cost, or is it going to replace funding for something else?
Yeah, so it won't replace, it will be so we can expand. So particularly for uninsured and underinsured. So those particularly coming out of the jail, when they come out, they don't have any insurance. So they can't apply for Medicaid until they're actually released from the jail. So there's a period of time in there where they don't have any insurance. And so this would certainly, cover that cost. And then we just have those in the community as well. And
Yeah, let me just add on to that. Because certainly, all of us operate under a budget. So our budget year suggests that there's only a certain number of patients that we can see as an organization, at all of our sites. So certainly we wish to expand the services because of the need. In order to expand, it will take some additional man hours, FTEs to do so. So that's really why we are here. As we see the need, but frankly, our budget does not suggest that we're able to meet that need going out into the future.
That'd be true, particularly if you expand your relationship with the jail, for instance, right? I mean, that's not an area is there active involvement in the jail today or not?
not currently.
Okay, understood.
Yeah, let me add to that because certainly we have met with Sheriff here on a couple of occasions. And certainly we wish to do that. We need to do that. But again, I look at our total amount of resources that are available, and we've been trying to maneuver our budget, resources, et cetera. How can we do that? So this would be extremely helpful to us.
Okay, thank you.
So one other quick question. I noticed in the overall program, you got three areas of cost: staff costs, lab services, and medication costs. And lab services is higher than medication. So what does lab services consist of?
Dr. Chu might be able to answer that better than I do. When people come in and they start on MAT services, there is a long list of labs, that we order, just to check overall health and then fit for the medication. I don't know if you want to say any more about that, Dr. Chu. He's the expert in that.
I think, as I said, that we are family decisions, so we care about the whole well-being. And, in terms of, say, for example, they had the HIV positive, we know that we can, refer to, for treatment. And if they had hepatitis C, we can treat it ourselves, but all those things, we need to understand whether they had any of those underlying medical problem. Some people maybe, they are on opioid and for a long period of time neglecting their health. They may have diabetes, they didn't even know that. They had high blood pressure, they didn't know that. They had high lipid and they had heart disease risk. So the reason we do all those labs is to really identify whether there's any underlying risk that we can treat with them. We are not a specialist only looking at the, treatment for the medication for opioid dependence, rather than to look at the whole well-being of the person. And that's why maybe the lab, we do a little more extensive compared to other group. So I think that's the reason why.
Sheriff?
So we had a pilot program with fentanyl and with Family Medical Center. One of the, other than COVID being an issue, we tried doing this during COVID and that, as we all know, was difficult. One of the other issues though, and one of the things that you cannot do is you cannot start medically assisted treatment and then not hand it off to someone. That's something that we have said many, many times. So one of the challenges is finding providers. So are you going to have that? Because throwing money at the problem is not going to, if you have no providers, you have no providers. And that was the hurdle that we had moving forward. And that's why we couldn't start fentanyl back up again, is because of lack of providers. Do you have a solution for the lack of provider problem? Not
Yes.
to put you on a spot,
No, you-
we've met many.
You're right. A couple years ago, we had one provider retire who was providing MAT SUD services. That's about 2 years ago. And recently, we had a part-time physician retire or leave, but we filled those positions just in the last 6 months. So we hire 2 full-time physicians. They're young. One has, both of them have about 3 years of primary care experience. Both of them are in our on site here in Adrian, and we're very happy about that. That means that they're going to stay for a while. So you're right. You have to have the staff to provide the service. And we believe we're properly now staffed to commit ourselves to this journey.
Thank you. Other questions? Terry?
How do you feel about the possibility, I'm a retired law enforcement, so I know a little bit about this. But people who are in the jail receive the treatment, do very well in the program, but when they leave, the hell with this, I'm done with it. I'm not gonna do it anymore. How are you gonna deal with that?
Well, I think part of what we do with that is when they come out, obviously, is to try to get them connected right away.
Right.
I think that's a critical step. The other piece that we do is we try to wrap them around, so it's more than just prescribing the medications. So again, the peer recovery coach is a key part of that. We also try to connect them with a master's level therapist to provide ongoing therapy. And then community health workers as well, trying to identify what are those social determinants of health. How long have they been in jail? What are they coming out to? Do they have housing? What are the employment issues? Drivers, transportation issues, all of those sorts of things. So we really try to wrap them around with some services.
This is done virtually simultaneous with release.
Yep. So when they come in our door, that's again, part of what kind of the cost and the staffing cost comes in as well.
Yeah, let me just add to that, because when Dr. Chu started up on this program, it was only Dr. Chu. So he came to us, and just as he explained to all of you, he explained to us about the need of the peer support individual, the nurse, the other issues that that person might be facing. So we have for instance, a psychiatric nurse practitioner, full-time, working at our agent site. So we all know that some of these individuals have behavioral health problems beyond just, their drug, issue. They need help. We have the resources to provide that help beyond just primary care. They need dental treatment. We have a dental unit there. They need glasses. They can get glasses. So as I was saying, our Adrian site is well positioned to serve that whole individual.
All right, oh, Judge Morgan?
You indicated, I believe on the slide, the dollar amount was, I want to say close to $300,000, like 290 something. And you had requested 200,000 from us. Now, these funds are limited. We basically are able to provide maybe one, maybe two, but not necessarily indefinitely. So how would you sustain that?
I wish I could answer that. So one of the things that we're hopeful that, and we talked to the sheriffs about this, and also the other individuals in the community that come to us. Many of them are eligible, or some of them, not all of them, are eligible, say, for Medicaid. So we all know what's happening with Medicaid, or could happen with Medicaid, in the future. We understand that as an organization. But as Dr. Chu pointed out, when that individual starts with us, they stay with us for as long as needed. So that is about $139,000 difference, if I remember that number. It's in there because we will provide that sort of financial support through our ability to bill whatever third-party payer that person may have. And we know from our experience with all of our patients, there's always that gap that we need to fill through grants or whatever.
Thank you. I am going to take one liberty as chair and ask one question outside our time limit. We've had a number of proposals for telehealth options, including for young people, but also in the jail. Do you guys have any experience with telehealth, and would you care to offer an opinion on what kind of role that might offer? Is that something we should be looking at as a county?
At telehealth, one provider working with telehealth for the buprenorphine program. For that, the disadvantage is we need to monitor to make sure the patient taking the medication. We need to have a drug screen. If we didn't take the medication, we give the medication, we don't know whether it's on the street or somewhere else, and the person still is in a problem stage. So that's why we don't always encourage that, but we providing that under certain circumstances. For some people who is not able to come to our center, such as, we had people who had paralyzed or something that they still need to,
Sure.
treatment. So we give them the medication, but, with telehealth, we did have that for buprenorphine program with one provider doing that. We also do it that in times of a patient who, for example, they happen to be, the car doesn't work.
Right.
Okay, then we providing that service, to help them and not to get them to the hardship of relapsing back.
Sure.
We try our best to help all the people that in our program.
Thank you. Well, thanks, folks. I appreciate your time. Give a logistic note. We don't believe that our fourth presenter will be making it today. So that's why I was not afraid to run over a couple minutes. Next, I'd like to welcome Mr. Martin, who is, get to my sheet, here with Goldie Health. Reminder, you have 20 minutes to present and then 10 minutes for questions.
That works out perfect. I have a flight coming up in a few hours, so
Okay.
move as
super.
quick as I can. I appreciate all of your time being here. This is, arguably the most pressing issue pressing this community in our country everywhere. So, applaud all the time and effort and resources you're bringing to bear to take a look at this. I'll quickly go through this. This county has, roughly 100,000 population. Based on statistics, it's about 2,000 individuals that are extreme high risk. Beyond the loss of life, every single person that's suffering from opioid use disorder in Michigan is costing about $750,000 per year. 2 to 3% of that can be attributed to the county, so it's a significant cost. General statistics show that only 30% of overdose survivors receive any follow-up care, and that's including primary care physicians. So it's a very underserved issue. The biggest stat that we focus on and why Goldie started is only 6.4% of overdose survivors are connected to MAT, which is the gold standard of care within 30 days. I don't know if they touched on it, but the use of buprenorphine it's a miracle drug, 70% reduction in fatalities. It is the gold standard. It's, arguably 5 to 10 times better than brick and mortar treatment centers. So that, irregardless of Goldie's place in here, MAT has to be part of the solution. Otherwise, you're not going to be able to really address the issue. What Goldie really addresses, there's this significant amount of friction in the system between acute care, between follow-up care, and between community health. And that's largely what we address, is we are trying to do everything we possibly can to drive up the 1 in 20 that's currently receiving treatment within the first 30 days to drive it up to 14 or 15 and 20 over the first 30 days. So what is Goldie? Goldie is essentially connective tissue. We're an operating platform that counties use. We're in numerous counties in the Southeast. We recently were selected by Baltimore, which is the overdose capital of the United States per capita, to power their ecosystem, including 18 hospitals and Johns Hopkins. So we do deep integrations with EMS, with the hospital, with community health, with jails, any systems that the county wants us to integrate with, we include that in an integration, constantly monitoring the data. We're seeing individuals that have recently had non-fatal overdoses, individuals that are at risk of overdose. So that's one of our core competencies, is being the best connective tissue, best in class integrations. We think that's the most crucial part of this. You can have the best downstream MAT providers that you can have, but if you're lacking the connective tissue and the technologies to bridge these silos, you're really still only going to be addressing the 1 in 20 at the end of the day. Looking from a high level standpoint, so this is pretty directionally correct based on data from this county as well as data from about 1,000 other communities across the country. So this gives you an idea of the difference between having a system that's connecting all these various silos and improving the detection, and then improving the care cascade through every single step of it. So right off the bat, we typically see from a detection standpoint is we detect about 100% more. So if you look at EMS, we detect about 30% more. Hospitals, we detect about 300% more. And then in various other care settings, we detect between 25 to 200% more. What that ultimately means at the end of the day is that if over the course of the year for the county the size of this county, we would have about 300, we would expect to have 350 people that were engaged in treatment after the 90-day metric compared to 10 or 20, what we traditionally see when we enter counties before a platform. And an economic savings, and again, this is all in, what could be attributed to the county would be about 2 to 3% of that. Goldie was created at the University of North Carolina, which is one of the leading addiction research institutions in the country. along with a collaboration with the Collaborative Fund in North Carolina, which is a science-based funding solution to tackle social issues. And with MAHEC and Eshelman Innovation, we have since spun out of the university and we have venture capital backed. And so we have significant financial backing as well as research institution backing. From a personal standpoint, my mom was an addict. My brother passed away from opioid overdose. So this has been my number one focus over the last 10 years, is creating technology to address this problem. And then a little bit about the team. I've been in healthcare, largely in EMS, scaling companies from 1 to 100 million, 25 years in EMS, behavioral health, mental health, and then also on the technology side as well. Our chief operating officer has 25 years of experience in healthcare. Dr. Shukla is one of the top addiction research physicians in the country. And then Michael Plockton, who was the chief technology officer at Sony Electronic Arts, worked at Apple for 5 years, was actually hired by Steve Jobs and worked with him personally for 5 years. So he's the chief architect of our platforms. And then these are their founding partnerships. So University of North Carolina, MAHEC, Eshelman Innovation, AWS, and then the Collaborative Fund out of North Carolina. So I tried to get through that as quick as possible, really leave as much time for questions that you may have.
Questions, Sheriff?
I always go to the jail, that kind of question. So is this search engine currently hooked up with all of the providers?
Oh, Sheriff, turn your mic on.
Is this search engine or detection engine hooked up with any of the jails in Michigan or anywhere around? Are you into like VitalCore, who is our provider, healthcare provider, or any of the other jail healthcare providers?
We are integrated with jails, not VitalCore. We've had conversations with them. It's not a hard integration to do. We've gotten far enough along to discover kind of the lift of doing so, and we would be able to do that integration.
Sarah?
So help me understand. If I were the addict or the high-risk person, how does your platform help me directly?
That's a good question. I would say what typically happens, again, 19 out of 20 people, the typical vicious cycle, someone has an overdose, either they go to the hospital directly or they're transported by 911, they're administered naloxone, they're stabilized for 2 or 3 hours, they're told to follow up with the primary care physician. Maybe there's some efforts made to contact a local resource, and then that usually doesn't happen. After the 72 hours, patients typically lose that initiative to really follow through. From a social determinants of health, about 50 to 70% of these individuals don't have reliable transportation. And so if you're not offering a virtual MAT solution, you're going to be leaving 50 to 70% of these individuals out in the dark, because they're just not going to follow through. They might go to a brick and mortar once or twice, but they're not going to continue. So a virtual MAT is a crucial part. It can't be the only part. Like, you have to have local brick and mortar providers, like the individuals that were previously up here. But that's usually what's missing. And so us, with that connective tissue, we're connected to the downstream providers. And so we're seeing when they go to the hospital. And so we're instantly engaging community-based resources to create that engagement within the first 2 or 3 hours. We're following up with the patient. Within the first 6 hours, 12 hours, we're engaging peer support specialists. We're finding out what kind of insurance they have. What are the appropriate downstream providers? Do they have reliable transportation? If they do, and this MAT provider, do they have the insurance match? If not, we're finding those matches. What's that care coordination team look like? And so we're the one kind of coordinating all of that, behind the scenes, and really kind of coordinating, acting as kind of the conductor, so to speak. And that's what's usually missing. It's a lot of well-intentioned people generally that are in their silos trying to do their the best they can, but they're not connected. You know, jails and law enforcement is not connected to peer support specialists generally. They're not connected. They don't know if they've been to their MAT follow-up, 30 days from now, 60 days from now. So there's a tremendous amount of watered down and friction, throughout the system. And so every single patient that we detect, we can look at the life of that patient over the course of years and see every single touch point, every single provider, what their social determinants of health are. Has that changed? Do they have reliable transportation today? Should they be in the brick and mortar substance, treatment center? So like all of that, like we even look at like, do they have reliable housing? And if not, like we're lining up housing for them from a shelter standpoint. Do they need wound care? Do they need, syringe program? So all of that is constantly like a whole health perspective from a behavioral health, mental health, and substance abuse, system, tying in this ecosystem of what could be, 10 different providers and a mixture of, EMS, law enforcement. So that's essentially what we're doing. We're acting like a really technology-enabled, kind of robust case manager.
Thank you.
Sheriff, then Terry.
Are you currently hooked up with MAPS,
MAPS is in,
Michigan's prescription drug monitoring system?
we're not. This would, to be transparent, this would be our first county in Michigan.
Okay.
Terry?
I may have overlooked it, I can't find it, but what level of funding are you asking for?
So our level for Goldie ourselves would be, I think it's 65,000 a year. That's including integration. So that would decrease over time once we got through the integrations. We do have a subcontractor for virtual MAT, but that's really flexible based on the other providers and other offers that you've kind of had from other, providers like the previous provider. The subcontractor that we brought to the table with this is Bicycle Health. They're the largest in the country. Thousands of providers, thousands of peer support specialists. They help individuals get on Medicaid if they're not on Medicaid. We're not suggesting that they would be the only provider, but we do strongly suggest that there needs to be a virtual MAT element. It doesn't have to be them. So if it's not them at all, the all-in cost is 65,000 for the first year, and then it kind of decreases following years as the integration cost, drops off.
But why don't you, since we've had a proposal from Bicycle Health directly to us, could you explain to us kind of the boundaries, the overlap between you and them? And so for instance, they didn't mention you when they were here. So explain to us this relationship and what this would look like for us on the ground.
Well, they didn't do a separate proposal. So they're included on our proposal, but they had to present separately. I'm not sure of.
I guess I wasn't clear on that.
Yeah. So again, I mean, they're only part of this because they're a subcontractor on our proposal. And again, like the way we've structured it, their cost, which I believe is 70,000 per year, that would be all inclusive. That would cover the indigent exposure. That would cover enough services to service 100% of the MAT requirements. That would cover them helping to do Medicaid enrollment. They even have a phone program if individuals don't have phones. So that is the maximum that 70,000 per year would cover 100% of MAT services. Now, granted, it would all be virtual, but that's the maximum. I think, you guys would have to look at and see what other local options do you have, like the previous individuals. Bicycle could be 0 or it could be 70,000. I think, we see counties that they don't have any MAT options. And so in those cases, Bicycle Health is a perfect solution. But if you look at like their engagement, like it's usually, 2 times higher than most of the providers. So they are a best in class provider. But I do believe, some local MAT is part of the solution. Sometimes that's just not available. If it's available in this case, it should be utilized, and their amount would be, less depending on that.
So your proposal, which was $540,000 for 4 years, is really as proposed, and you say you're open to other vendors.
Yeah.
Your proposal would be a 2-part relationship really with you and Bicycle Health.
Correct.
And the area that you're furnishing is what? Just the first layer of data
We
assembly and then,
provide the data integrations, the applications. So like any community-based resources, or really anybody that wants to use our app, we have unlimited license. So if peer support specialists, if EMS wants to use it, we have some hospitals that want to use our platform. Whoever wants to use it in the county, even if the previous provider is in here, if they wanted to use our app, like we believe the more people that use our app, that's part of the ecosystem, the better the care delivery is.
so if we got EMS from, let's say, Madison Township, because they're a big provider of, you know, ALS and all this stuff, what's their interaction with you gonna look like at a scene somewhere?
They would be using our app. So our
What are they gonna tell you?
Yeah, our app would be integrated in with the, EPCR, which is the EMS, EHR essentially. So we'd be integrated with their EHR. We'd be seeing, what are individuals at risk, and the individuals that are at risk, typically what EMS will do is they'll have a post-overdose response team that's kind of part of EMS, but kind of separate from EMS. It'll be a mixture of medics and a few peer support specialists. And those individuals, instead of using like a Zoll or something like that, they would be using our app, which is a purpose-built EHR for substance use disorder as part of our ecosystem. And then we have like the integration layer, we have the administrative portals, we have, depending on what the user is, if you're a hospital user, you have your own experience. If you're a community health worker, you can use a mobile app or you can use a web app. You're a health department and you just want to see analytics. We have the portal so you can see, analytics and, how many people have been seen, how many people are still retained, very powerful, as far as the, the versatility of whether it's a mobile, native app on an Apple phone or Android phone or web-based.
So they're gonna tell you, we got a guy named John Doe and he's had this,
They won't even have to say that. John
Okay.
Doe will show up. Like we will monitor the data and we'll say John Doe had an overdose. We'll automatically, tell the post-overdose response team, John Doe just had an overdose. Or could be that John Doe had a broken arm, but John Doe is also, on opioid use. He's disclosed that he's on opioid use. He's indicated they'd be receptive to treatment. That would also, pop up in the data, and whoever the appropriate, provider was, they would all automatically be connected.
so that
Have
first
this-
layer of data would come from either first responders, either EMS, law enforcement, and they would be able to enter that into
Yeah.
the system. Then hospitals, mental health providers, whatever, if they're integrated in the system, would be able to see that, and there'd be a database created around that person.
Yeah, to the extent possible, we don't want to create double data entry. So that's why we want to do as many integrations. Like we don't want EMS to be typing in John Doe into another system so we can see it and everybody else in the care network can see it. We want to have the integration so that when the data shows a John Doe that had an overdose or is in need, we're automatically grabbing that. No one's having a double data entry because that's a big part of the problem. Like when people have the double data entry, they just don't do it like 50% of the time.
Sure. Any other questions? We are out of time, but well, thank you, sir. I appreciate your time. Certainly fascinating concept.
Thank you. Thank you, everybody.
Any housekeeping among us, guys? Are we feeling any questions, any other ideas that have come to mind? We continue to work our way. How many do we have left, Francine?
We have 2 November 19th and 2 in December.
Okay. Then we're gonna think about then when nobody's gonna say that we want to do something like the week of December 20th. So we're gonna want to look then at our schedule, probably after the first of the year to, then come back and start to do, I think, the harder level of processing. It's interesting, the things we continue to learn about various proposals just by hearing more from more and more folks. It's been fascinating. Sarah, yes.
Are the yoga people a no-show or
Correct.
reschedule? Are they a reschedule or do we not know yet?
They are not rescheduled.
Okay, thank you.
Yeah.
Thank you.
And again, another reminder to avoid the shame of having your name on the screen. Please fill out the rest of your evaluations if you've missed them. Anything
Motion to
else?
adjourn? Oh, yeah, public comment.
Yeah, I see no public comment. Is there any public comment? Seeing none, I would entertain a motion to adjourn.
So moved.
Second?
Or
Been moved and seconded multiple times. All in favor, say aye. Meeting adjourned. Thank you, folks.